for people listening, translational medicine in general would be considered bench to bedside. That's like the standard definition. And basically translating the findings in the lab on the bench to the bedside of the patient through the clinician.
Right.
And, one of the interesting things that I've found running the hospital and being so involved is I think from the outside, most people think that doctors are scientists.
Right.
And scientists, and somehow, and that really was the case, 50 or so years ago. It was more of the case where clinicians would make discoveries and they would notice things and they'd, really expand upon that. But what you're saying is actually a little different. I haven't ever thought about that way, bench to bedside, back to bench. Mm-hmm. And, I like hearing that because that's kind of the model that we have set up in Mexico, where we have, our sixth floor cellular lab, we have our clinical lab, genomics lab, digital pathology, and the doctors and scientists work area is the same. So they're working collaboratively to do that.
There's a couple of things to point out, I think. One is the majority of the way medicine's practiced right now, physicians have to be operational. They're not given enough time because of the way it works to really devote as much time as they might like to devote to understanding the patient and their condition. And the patient is putting pressure on the physician to come up with a diagnosis and a treatment. And actually, the internet doesn't necessarily help because they're coming in armed with all kinds of information and misinformation. And the doctor frequently has to sort through that as well. So it's not a perfect match. One of the things we've tried to stress is let the doctor be operational, but let's find out what is the strategic side, not the operational side, that they really could benefit from having more effort to be involved in. And, a common thing would be, an easy thing to understand, the doctor has to come up with a diagnosis, okay? The diagnosis gets tied to treatment, it gets tied to reimbursement, hopefully to improve patient outcome. But they don't have time to really study the underlying pinnings of what the diagnosis actually means. And so we spend a lot of time exploring how do you make a diagnosis? How accurate is that diagnosis? Does the disease have to be stratified? Because maybe there's 5 different subtypes in that diagnosis.
Yep.
And the doctor doesn't have the tools necessarily to apply it that way unless they have the experience already and they've seen it. So we try to take that on. Now, why that's important is when I left academics, we were trying to do a lot of that, but it wasn't sort of the current model. And there were a lot of things we were trying to do because this was very early, and it gets to the model that you have in Mexico. We're trying to say, instead of trying to take all the databases and put them together, the way people even now try to do, let's change this and make it a patient-centric model. Because in essence, the patient owns everything. They own the tissue, they own the disease, they own their lifestyle, their environmental exposure, their culture, their social determinants. And let's make it patient-centric because that really is what is all about. And let's use that as a computational model as well, because now we can make the model of all of the data represent the patient. And we can ask questions about that.
Yes.
That wasn't the way things were going at the time, which was around 2004 in the academic medical community. And so that's when I left to run the Winber Center, which was a Department of Defense breast cancer center, working with Walter Reed. Because whereas where I was in academics, I kept being told, well, we can't do that. That's not the way we do it. When I presented it into the DOD, it was, well, if it makes sense, we'll do it. And we don't have those barriers. We don't have those structures.
What was that like? Like when you were able to do that and go from all the barriers to being open, what did you accomplish?
We could ask questions that we couldn't start to ask before. We would see things, relationships among data, among patient characteristics. We would see, the most important thing is we could start to better see where there were gaps and conflicts. Because the thing about science is it's constantly evolving. And it's never going to be perfect. You're never going to understand everything. But if you can identify where there are gaps and conflicts, you have a better idea of where to prioritize your research and your investment. Which ones are important? Where will you get the return on investment, so to speak? And changing the model gives you more freedom to do that, because we weren't going to have to align with what was an NIH review panel going to want to do when everyone on the panel did the same thing.
Right.
And you're trying to change something.
Yeah, give an example working for the DoD, a change that you were able to make that made a positive difference.
Well, the data model, we went from the concept of an EHR, electronic health record, where you would put all your data in, to a personal health record. And that started to then, so the idea would be a patient who would come in to a doctor's office and you would ask, do you smoke? Do you drink? How much do you smoke? How much do you drink? Because I'm trying to assess your risk for breast cancer. But the reality is that patient actually undergoes developmental change from the time they're a fetus during pregnancy all the way through the rest of their life. And the breast is actually a perfect example of that. There's 10 different stages of breast development just during gestation. And exposure to these factors like smoking, or which aren't from the fetus, of course, but maybe the mother and the environment, they're going to have different effects at different points in time of that development. So risk is not something that is as convenient to model as asking, do you smoke? And maybe you should stop smoking. It's maybe when you were smoking at the time of menarche, that was when risk actually developed. But we couldn't ask those questions the same way, but we were free to do that kind of modeling and expand upon that with the DoD experience.